The most common conditions which lead to joint replacement are osteoarthritis, rheumatoid arthritis, post-traumatic arthritis, and in some cases, osteonecrosis. The most common being osteoarthritis is associated with aging or wear and tear. Rheumatoid arthritis is usually associated with autoimmune problems, which leads to synovitis or inflammation of the joints and ultimately bone loss. Post-traumatic arthritis usually develops years and years after a major injury and is oftentimes preceded by other surgical procedures to try to repair that traumatic injury. This is a model of a knee joint, and it depicts the knee that has the skin removed, the subcutaneous layer of fat just below the skin, and then right down to the tendon of the quadriceps muscle, which contains the kneecap or the patella, which eventually attaches to the tibia. In the process of doing joint replacement surgery, we perform what's called an arthrotomy, which means an incision around the joint capsule, and we usually subluxate or dislocate the kneecap. Most surgeons will resurface the back portion of the patella, which means using an instrument to remove the worn down cartilage and subchondral bone and prepare it so that you can cement or glue a plastic patellar component to the back side of the kneecap. Following that, we will flex the knee up and prepare the end of the femur to accept a femoral component. And this involves making several cuts, one at the end of the bone, one on the top of the bone, one on the bottom of the bone, and two angled cuts in the middle of the bone so that the implant, which is fashioned in the same manner as the cuts, can be placed on the end of the bone and secured with bone cement. And the final preparation involves the upper part of the leg bone or proximal tibia. And in order to prepare the proximal tibia, it requires removal of one of the main cruciate ligaments, and in some cases, both cruciate ligaments, both the ACL and the PCL, removal of the entire meniscus, and removal of the cartilage and subchondral bone. And so you've got three components: a tibial component, a femoral component, and the patellar component. And after we've resurfaced each of the components, we will reduce the knee, put the quadriceps back in front of the knee, and repair this arthrotomy on the inside part of the knee. And following that, we'll close the skin, and that's how we perform a knee replacement. Certain risk factors we know have an adverse outcome on joint replacement. These risk factors include morbid obesity, uncontrolled diabetes, and actually the need for chronic pain medicines. We know that someone on chronic opioids does not have a good outcome compared to other patients not on chronic opioids who undergo knee replacement. We know that patients who don't have controlled diabetes, and we define control with hemoglobin A1C under 7.5 or 8. We know that patients without controlled diabetes are going to have more complications than patients who do have good control of their diabetes. And lastly, we know that the pain relief associated with joint replacement is going to be much better in someone who has an ideal body mass index compared to someone whose body mass index is greater than 40.